Thank you for viewing the Centers for Medicare and Medicaid Services Cost Measure Field Testing webinar, which will provide information about the field testing of 5 episode-based cost measures before their consideration for potential use in the Merit-Based Incentive Payment System, or MIPS track of the Quality Payment Program. Due to the ongoing COVID-19 public health emergency, please note this is a recording intended to be a resource for its stakeholders to access as they are able. So now I will turn it over to Dr. Ronique Evans from CMS to begin the presentation.
Thank you. My name is Ronique Evans. I am the Cost Measures Lead for the Division of Quality Measures at CMS, and I will go through the next few slides for our introduction before handing it over to our measure development contractor. Next slide. This CMS disclaimer outlines that this presentation is a general summary intended as a reference document for stakeholders, but is not a legal document, and Medicare policy can change frequently. Next slide. Today, we will provide an overview of the cost measure development process, the 5 episode-based cost measures being field tested, materials and activities that are part of this year's field testing, and what information is included in the field test report. Next slide. Here are a few acronyms we will be using throughout the presentation that you may find helpful for reference. Next slide. To begin, I will go over the background for the MIPS cost measures. Next slide. The Quality Payment Program has 2 tracks for clinicians to choose from: Advanced Alternative Payment Model and the Merit-Based Incentive Payment System, MIPS. Clinicians participating in MIPS have their performance assessed across 4 categories: quality, cost, interoperability, and improvement activities. A clinician's performance score for each category is rolled up to a MIPS final score, which then determines a payment adjustment. CMS is developing a new participation framework called MIPS Value Pathways, or MVPs, as a way to connect the quality, cost, and improvement activity categories. The goal of the MVPs is to simplify participation in MIPS and to provide clinicians with a set of aligned measures across performance categories that are meaningful to their care practice. Today's presentation will focus on the cost performance category of MIPS. The MIPS cost performance category started with only 2 global or population-based cost measures and has now expanded to also include 18 episode-based cost measures that covered a wide range of conditions and procedures. All of these cost measures are calculated using administrative claims data, so there is no additional reporting required for clinicians. In 2020, the cost performance category makes up 15% of the MIPS final score. Next slide. We are currently developing and field testing 5 more episode-based cost measures that could potentially be used in MIPS in the future. An episode-based cost measure represents the Medicare payment for the medical care provided to a patient related to a specific episode of care. These measures only include the cost of relevant services in the episode, such as direct cost of treatment or services resulting from their treatment. The measures intended to inform clinicians on their costs for patients so they can identify opportunities for improvement are based on 3 types of episode groups. Acute inpatient medical condition measures focus on the treatment for an exacerbation of a condition requiring hospitalization, such as hospitalization for stroke or pneumonia. Procedural measures focus on a procedure of a defined purpose or type, such as spine fusion surgery or screening colonoscopy. Chronic condition measures focus on treatment for an ongoing clinical condition at the time of a medical visit. These use a new framework, so we are especially excited about being able to include these for the field testing this year. In addition to the 2 chronic condition measures, we're also field testing measures for melanoma resection, colon and rectal resection, and sepsis. Next slide, please. We conduct field testing as a part of the development process for episode-based cost measures, so this is the 3rd time that we are holding the field testing period. We conduct field testing so that stakeholders can learn about and provide feedback on the draft measures. During this time, we distribute field test reports on the Quality Payment Program website, post draft specifications and supplemental documentation on the MACRA feedback page for folks to review, and collect feedback on the draft measures to inform refinements to the measure. This period will take place from August 17th to September 18th, 2020. I will now turn the presentation over to Joyce Lamb from Acumen, the measure development contractor.
Thanks, Renique. My name is Joyce Lamb, and I'm the project manager from Acumen for the Cost Measured Development Project. I'll start by providing a brief overview of the cost measured development process. Next slide, please. Our measure development process involves gathering extensive stakeholder input to ensure that the measures are clinically valid and can meaningfully assess a clinician's cost of care. The episode-based cost measures are developed in cycles, or waves, where development activities take place on the same timeline. So far, we have completed 2 waves of development in 2017 and 2018 and created 19 episode-based cost measures. We are now in wave 3 of development, which began in 2019, and we have engaged with over 160 members who have shared their input and expertise. Next slide, please. This development process involves convening multiple panels, each of which serve a distinct role. We have a standing technical expert panel, or TEP, which provides high-level guidance for topics across the project, such as the measure framework and criteria to prioritize measures for development. Within each wave, we convene clinical subcommittees, which are large panels of clinician experts focused around a particular clinical area. These subcommittees review empirical analyses and input from the patient, family, and caregiver perspective, along with their own clinical expertise and experience, to provide input on candidate episode groups using the prioritization criteria that the TEP helped to develop. In addition, the subcommittee provides input on the desired composition for a smaller panel that will build out the measure. This clinician expert work group provides detailed input on every aspect of the specifications across multiple meetings. This iterative process allows for ongoing testing. Also, by having a smaller work group to do this detailed building of the episodes, we're able to be more nimble and really focus on the types of clinicians who are most involved in providing care. In wave 3, we convened 4 clinical subcommittees and 5 clinician expert work groups that have been helping us to develop the 5 measures that are now being field tested. Next slide, please. Here, we provide an overview of the development timeline for the wave 3 measures so far. The clinical subcommittee and clinician expert work groups have met several times at in-person and virtual meetings since mid-2019 and have discussed the measure scope, service assignment, exclusions, and risk adjustment. At each of these meetings, they have reviewed empirical analyses, environmental scans, and literature reviews, and considered the patient and family perspective. After field testing, we will share all the feedback that we receive about the draft measure specifications with the clinician expert work groups, who will then help to finalize development. Next slide, please. I'll now walk through the construction and the overall intent of the episode-based cost measures in further detail. Next slide, please. With input from the TEP, we have developed a framework for episode-based cost measures. This framework provides consistency across measures and is based on key principles like having assigned services that capture the role of the attributed provider. It is also flexible enough to accommodate a wide variety of clinical care that the episode-based cost measures cover. In waves 1 and 2 of development, we focused on developing measures covering acute inpatient medical conditions and procedures, as these types of care are both limited to a defined period, so share many similarities. In contrast, chronic condition measures assess care that does not have a specific end. Next slide, please. The acute and procedural episode-based cost measures are constructed and calculated in the same basic steps that I'll walk through here. First, we define an episode group by determining the codes that trigger or open an episode. For greater granularity, measures can be stratified into a set of mutually exclusive, exhaustive patient cohorts called subgroups. This stratification for clinical criteria allows for more meaningful comparisons, such as by comparing only patients with type 1 diabetes with other patients with type 1 diabetes. Second, we attribute the episode to a group practice or individual clinician. The attribution rules are closely tied to the triggering logic. Third, we assign costs to the episode for clinically related services. This set of services are determined through expert input and testing in consideration of the role of the attributed clinician and the types of care that they can reasonably influence. We use standardized costs, which removes variation payment that is not due to clinician care choices, such as removing geographic differences in labor and adjustments made under Medicare programs, like for graduate medical education. By summing all these costs, this becomes the total observed episode cost. Fourth, we apply exclusions to remove certain episodes from measure calculation. These exclusions ensure that we have complete data for each episode and remove episodes that are so different that they can't adequately be accounted for through other techniques, such as through risk adjustment. Fifth, we calculate the expected cost for episodes by applying a risk adjustment model. This model adjusts for factors outside the clinician's control that can affect the cost of care, such as the patient's pre-existing conditions. By accounting for this, the risk-adjusted measure ensures that providers are not penalized for treating more complex patients. Sixth, and finally, we calculate the measure score as the ratio of the standardized total observed episode cost from step 3 to the risk-adjusted expected episode cost from step 5. This ratio is averaged across all episodes attributed to a clinician. We then multiply this ratio by the national average observed episode cost to obtain a dollar figure. Next slide, please. Here, we illustrate how the episode construction steps capture care for an acute illness or procedure. As shown from the triangle diagram, this is a defined episode of care that is anchored around a trigger event, showed by the large teal triangle. From this point, the episode window captures services occurring downstream of the trigger service and can also include a pre-trigger period to include services such as preoperative image or testing. The trigger and attribution logic are designed to identify clinicians who are playing a key role in the episode. For acute measures, the episode trigger is an inpatient admission identified through MSDRGs. The episode is attributed to any clinician group, or TIN, that bills at least 30% of the evaluation and management, or E&M, codes during the trigger inpatient stay. For attribution to individual clinicians, the episode is attributed to each clinician that bills at least one E&M code within that group that meets the 30% E&M threshold. This logic is designed to reflect the team-based nature of acute inpatient care. For procedural measures, the episode trigger is the CPT HCPCS codes representing the service. The clinician that bills the service is then attributed the episode. Next slide, please. Moving on now to the chronic condition measure construction. These are constructed to account for the ongoing nature of care, so there are some differences between how this measure looks and the acute and procedural measures. The steps are also illustrated on the following slides, so I'll be quite brief here. First, we identify the patient cohort by looking for a combination of services that indicate that a clinician-patient relationship focused on a particular type of chronic care has begun. Second, since chronic conditions are by their nature ongoing, we identify the total length of time of this clinician-patient relationship by looking for additional services that indicate a continuation of the relationship. Third, we define an episode as a period of at least 1 year that is assessed to the attributed clinician in the study period in which it ends. This episode forms a unit that allows us to examine costs and compare clinician performance. Fourth, the episode is attributed to clinician groups that provided the initial set of services that indicate the beginning of the clinician-patient relationship for this type of chronic condition care. Fifth, we assign services to the episode. Unlike the acute and procedural measures, though, we calculate the standardized observed cost as an annualized figure, as episodes can be longer than 1 year. Sixth, we exclude episodes for the same reasons that I walked through for the procedural and acute measures. Seventh, we calculate the annualized expected cost by risk adjusting for factors outside of the clinician's influence. Finally, the measure score is calculated as the weighted average of the annualized observed over expected episode cost ratios across all attributed episodes, where the weighting is the number of assigned days during the episode. We do this weighting to account for longer episodes. We then multiply this weighted average episode cost ratio by the national observed episode cost to generate a dollar figure. Next slide, please. These next two slides provide some diagrams to illustrate key parts of the chronic condition measure construction framework. As mentioned, we identify the start of a care relationship by looking for a pair of services built by the same TIN within 180 days of each other. This opens what we call an attribution window, which is a period of time in which we monitor potential services for inclusion in the episode. This attribution window can be extended if we see a claim that reaffirms that the relationship is ongoing. If there are multiple reaffirming claims, as shown by the striped and spotted triangles here, each will have the effect of extending the total attribution window. Next slide, please. The total attribution window for a chronic measure begins with a trigger claim and concludes 1 year after the final reaffirming claim. As a result, this window can span multiple years and vary in length for different patients. To create comparable units, we define an episode as a minimum of a 1 year segment of the total attribution window that is assessed in the performance period, such as a calendar year, in which the episode ends. This diagram illustrates how a total attribution window is divided into episodes. Episode 1 is assessed during performance period 1 because that is the performance period in which the episode ends. I know this is a lot of detailed information, so I wanted to just mention that the version of the slides posted in the QPP webinar library includes an appendix with more detail on each step of measure construction for the acute and procedural and chronic condition measures. Next slide, please. Now that we've covered the measure construction, I'll discuss each of the way through measures in a bit more detail. For the purposes of field testing, we're providing reports to clinician groups and individual clinicians that have at least 10 episodes for the acute and procedural measures and 20 episodes for the chronic condition measures. Out of the 5 measures being field tested, as you can see in this table here, the 2 chronic condition measures for diabetes and asthma COPD cover the most TINs. Next slide, please. Here we list the top 2 most frequently attributed specialties for each measure based on the self-reported HCFA specialties. The number of TIN NPIs is based on attribution at the clinician level. The column for share of specialty shows the number of attributed clinicians of that specialty over the total number of clinicians with this specialty. That is, around 10% of all dermatologists would be attributed the melanoma resection measure. From looking at the table overall, as you can see, it covers a range of specialties as expected. Next slide, please. Moving now to the specifications of each measure in these sites, asthma, COPD, and diabetes are the first chronic condition measures to be developed. Our convened experts through the TEP and clinical subcommittee identified these as priorities for development due to alignment with MIPS cost and quality measures and the potential for impact through improving cost effectiveness for a large number of clinicians. The clinical subcommittee also considered that identifying a cohort for asthma COPD would be quite straightforward. While this would be more challenging for diabetes, the prevalence of the condition makes this a strong candidate for development. To identify the patient cohort, our team has worked with the clinician expert work groups to identify relevant diagnosis and CPT HCPCS codes specific to each measure. For example, the types of services that indicate treatment for asthma COPD could include a pulmonary stress test, while treatment for diabetes could be diabetes self-management training. Some of the opportunities for improved cost performance include managing ongoing treatment, as well as where appropriate disease management can influence the frequency or intensity of certain outcomes. For example, good management of diabetes could lessen the likelihood of certain complications or reduce the length of stay for, say, a heart attack. The measures also include standardized costs for certain Part D drugs. Next slide, please. For both chronic condition measures, patient cohorts are stratified into subgroups for more meaningful comparisons. This table shows the breakdown of episodes for each subgroup. Separately, it also shows the share of all Medicare beneficiaries that are covered by each measure subgroup. This is to provide a sense of the prevalence of these 2 chronic condition measures in the overall Medicare population. As you can see, both asthma, COPD, and diabetes cover a large share of beneficiaries, particularly type 2 diabetes, where almost 15% of Medicare beneficiaries are identified as having type 2 diabetes. Next slide, please. Moving now to the 2 procedural measures being field tested. The first is melanoma resection. One of the reasons that we are developing this measure is because dermatologists didn't have other episode-based cost measures available to them. So we focused on this procedure, which is quite common for dermatologists to perform. The measure is focused on procedures in the hospital outpatient and ambulatory service center, or ASC, and the episode window spans from 30 days prior to the procedure through to 90 days afterwards. This allows the measure to include the costs of diagnostic tests and post-resection treatments. The measure has two subgroups, head and neck melanoma and trunk extremity melanoma, because the location of the melanoma affects the complexity of the procedure and the necessary related care. The measure further risk adjusts for more specific locations of the procedure, as well as flaps and grafts, as these can indicate larger or more difficult resections. This table summarizes the breakdown of episodes in each subgroup and, as with the previous slide, the overall coverage of Medicare beneficiaries. Next slide, please. The second procedural measure that is being field tested is for colon and rectal resection. This measure focuses on both inpatient and outpatient procedures that partially or fully remove the bowel or perform a rectal resection. The episode window starts 15 days prior to the trigger procedure or the inpatient admission and ends 90 days after the treatment. The length of the post-trigger window was something that we wanted to highlight to show how our clinician expert work groups have incorporated the patient and family engagement perspective. When discussing the appropriate length of time after the trigger for certain services for non-specific symptoms, the work group considered that typically follow-up care for these types of services would occur within 2 weeks. From the patient and family perspective, however, we heard that while patients are commonly asked to schedule a follow-up visit within those 2 weeks, it often can take longer to schedule an appointment, sometimes just because other priorities get in the way. So for these non-specific symptoms, the work group landed on assigning these services within 30 days of the trigger, rather than the initial 2 weeks that they had been considering. Other types of services that are included are testing and imaging, rehabilitation, or managing medication side effects. The measure is stratified into subgroups for two types of procedures, colon and rectal resection, to account for the clinical differences between the two procedures and to create a more homogeneous patient cohort for comparison. Colon resections, as shown in this table, are much more frequent than the rectal resections. Next slide, please. Sepsis is the only acute inpatient medical condition that we have developed in this wave. The clinical subcommittee had discussed the challenges around defining sepsis, but also believed that this would be a very important measure to develop because of the high costs associated with sepsis and how common this condition is. To ensure patient homogeneity to allow for clinically meaningful comparisons, this measure focuses on the medical treatment of sepsis, not surgical. We capture different sources of infections by having episode triggers for the sepsis MSDRGs, as well as medical MSDRGs for common sources of infection, such as kidney or urinary tract infection, or UTI. Other sources of infection are risk adjusted for, or in cases where they are less common, are excluded. For example, osteomyelitis and septic arthritis infections are excluded due to their small case numbers and different treatment options that could affect comparability with other episodes. Next slide, please. The sepsis measure is also stratified into subgroups to account for severity, identified as sepsis with or without septic shock. The services assigned are related to the treatment of serious infections and downstream care, beginning with the hospital admission and ending 45 days after. These services can include testing and imaging, rehabilitation and aftercare, managing medication side effects, acute renal failure, readmissions for infections, and certain Part D drugs. The table outlines the number and percentages of episodes for each subgroup and the number of episodes for each source of infection that are accounted for through risk adjustment. Kidney and UTI and respiratory infections are the most common sources of infection in both subgroups for with and without septic shock. Next slide, please. Now we'll move to talking a bit more about field testing activities, materials, and the opportunity for you all to provide feedback on the draft measure specification. Next slide, please. As mentioned, the purpose of field testing is to provide stakeholders with information about the measures so that they can provide feedback on the draft specifications to help us finalize the measure development process. During this time, field test reports will be available to clinicians and clinician groups that provide information about how they would perform under the measure. We will also post the draft methodology and codes lists that contain detailed measure specifications so that clinicians can see what's included in the measures and how the measures are constructed. In addition, we've put together supplemental documentation that provides testing results and additional information such as summaries of the development process. As mentioned, we'll consider any feedback that we receive and share with the clinician expert work groups when discussing ways to further refine the measures. Next slide, please. The field test report will be available for download from the Quality Payment Program or QPP portal for clinicians and clinician groups who have been attributed the minimum number of cases for at least one of the measures. As mentioned, for procedural and acute measures, it's 10 episodes, while for chronic measures, the minimum is 20 episodes. There is a separate field test report for each measure that you meet the minimum number of episodes for, so you may receive more than one measure-specific report. Each report is in the format of a zip file with a PDF and corresponding CSV file of detailed episode-level information for each measure that you've been attributed. For those who participated in previous rounds of field testing, one difference this year is that the reports will be available on the QPP portal, which is easier to access as it uses the same account credentials that you use to access MIPS reports. For stakeholders who don't receive field test reports this year, a mock report is available on the MACRA feedback page for reference. We'll provide the links for the MACRA feedback page and other resources at the end of this presentation. Next slide, please. In addition, we've posted draft specifications on the MACRA feedback page. This includes measure methodology, which explains the measure construction, and the codes list, which details the medical codes used to construct each element of the measure. This includes the trigger codes, assigned services, risk adjusters, and exclusions. We also have provided a set of questions for each measure, which is intended to provide a starting point for folks to react to the measures for areas where we think that there is a need for more input. We have also posted supplemental documentation that includes testing results such as descriptive statistics about measure scores, breakdowns by provider characteristics, services of driving costs, and examining episode exclusions. In addition, we've made a summary of the measure development process, which provides more context about the various panels that have shared input to help develop the Wave 3 measures. We also have a fact sheet and FAQ document available. Next slide, please. You can provide feedback on the draft measure specifications of the 5 episode-based cost measures from August 17th through to September 18, 2020, through the online survey listed here. When submitting feedback through the survey, you can also attach a PDF or Word document with comments. Comments can be submitted anonymously if preferred. Next slide, please. Now that we've gone over the field testing process, we'll now provide more detail about the information that's available in the field test reports. Next slide, please. The field test reports are intended to provide information about how you would have performed on the measure as currently specified. Each year that we conduct field testing, we continue to update and improve our process based on stakeholder feedback. This year, we have made updates to the structure and format of the field test report so that it is a PDF to streamline the information and make it easier to access and review. An accompanying CSV file provides episode-level details for folks who are more interested in that granular data. The report also contains a summary of the measure specifications for quick reference. We've used this structure so that we can continue to provide that level of detail for those who are interested in this drill-down information, while also providing an easier-to-read format for summary information. If you meet the minimum volume of cases for a measure, you can download a zip file with these reports. The following slides will walk through the key metrics included in the field test report. Next slide, please. First, in the overview and results section of the report, we provide a high-level summary of the clinician or clinician group's results. This is intended to show the cost of services that you provided care for related to the condition or procedure and how this compares to other clinicians and clinician groups. The cost measure score indicates the average risk-adjusted cost for all of the clinician or clinician group's episodes. The national average cost measure score is the average risk-adjusted cost to Medicare across all episodes nationally. And finally, the cost measure percentile indicates the percentile of your performance on the score among all clinicians or clinician groups nationally. Next slide, please. In section 2, there is a comparison of your score to the national distribution. This is intended to show how expensive your episodes are expected to be relative to other episodes as predicted through the risk adjustment model. A lower percentile here indicates that your episodes are, on average, expected to be among the less costly episodes among clinicians and clinician groups. For acute and procedural episodes, the mean risk-adjusted cost for the episodes is the clinician or clinician group's measure score. Next slide, please. In section 3 of the report, we provide a breakdown of cost measure performance. This includes information on different ways characterizing what types of costs are included in the measure and provides a comparison of your performance to other clinicians. It also outlines which other clinicians are most involved in the care of your patients. Next slide, please. One way the field test report breaks down cost measure performance is by what we call clinical themes. These are categorizations of services that are mutually exclusive and exhaustive. These categories are created so that we can more easily show the areas which are important sources of cost and provide you with actionable information that helps you to understand what is driving the cost of your episode and make decisions for improving cost efficiency in care delivery. The clinical themes are specific to each measure. Here you can see an example set of clinical themes for melanoma resection. Some of these categories, such as wound care, may also be included in other measures. It also provides more granularity, such as for lymph node services, which is more specific and may not be included in other measures if it's not clinically relevant. Next slide, please. In this same table, we include how other clinicians in your same risk bracket who have a similar patient case mix and complexity are performing for each clinical theme as a comparison. This is demonstrated through the risk score bracket. A risk score is first calculated for each episode as a ratio of the expected cost for an episode to the average observed cost across all episodes for all clinicians. This is the expected risk for each episode. Your average risk score across all episodes is then placed into a decile within a distribution of average risk scores for all providers, which then is your risk bracket. Next slide, please. Finally, the field test report includes a section with additional information, such as a summary of key information about the measure specifications and methodology for easy reference. We also include a glossary of terms used within the report. We've included this in response to feedback that we've heard in the past that folks would like to have more information in the one place, so that it's easy to have on hand as a reference as they're reviewing the results presented in the field test report. Next slide, please. In addition to the PDF field testing report, each clinician who has the minimum number of cases will also receive a CSV episode level file and data dictionary. The CSV provides more granular information for each episode, including information to identify each beneficiary, clinicians and other providers who are furnishing care during the episode, and a breakdown of costs for each episode by setting. The data dictionary provides a definition for each metric used. Next slide, please. That wraps up what we wanted to cover for field testing. Next slide, please. So for more information about field testing, materials and resources will be available on the MACRA feedback page. Here we've also included the link to the QPP Access User Guide, which can provide information about accessing field test reports if you have any questions. And finally, we'd like to point you to the field testing feedback survey, where you can submit your feedback either through multiple choice questions or attaching a comment letter. Next slide, please. If you're interested in participating further in the measure development process, we plan to convene future waves of clinical subcommittees. Nominations are posted at this location once the nomination period is open. If you would like to be contacted when this happens, please feel free to add your contact information to our mailing list linked here. Next slide, please. Finally, if you have any questions about the information we've reviewed today, please direct your questions to the QPP Help Desk, which can be found at this email address or on this phone number. Thank you all for joining us, and we look forward to hearing your feedback during field testing. This concludes the recording.